Yeah, atrial fibrillation, or AFib, is basically a disorganized rhythm of the upper chambers of the heart, which are called the atria. So intrinsically, AFib has always been thought of as a benign rhythm. However, it's been shown that people in AFib live shorter than people that are not in AFib, what we call normal sinus rhythm. And with AFib, you have various physiologic changes that can happen to cause problems, meaning you can have low flow through the heart, which can cause congestive heart failure, which can cause you to be hospitalized more frequently. You can also have stasis, or again, low flow, which can cause blood clots to form in the heart, which can then fire off to other parts of the heart, meaning the brain or the body or the legs, and cause clotting problems. There's a significant percentage of stroke patients in the country have strokes due to embolic phenomenon from these clots that have formed in the heart due to atrial fibrillation and have then gone off to other parts of the body. So one of the main, that's probably the main concern with AFib is the development of clots and stroke formation afterwards. Symptoms of AFib are varied. In fact, they can go from completely asymptomatic, and people don't even know they have it until maybe they've already had a stroke, or they show up with some other problem, or symptoms can go to a racing heartbeat, palpitation, shortness of breath. Some people have this impending feeling of doom, like they're going to die. And that's usually because of a rapid response to the atrial fibrillation, a rapid heart rate. So the symptoms can really span across the board, but what makes it so insidious and dangerous is oftentimes it is asymptomatic, and you don't know until you've already had a complication from it. Patients that are asymptomatic often are picked up through a routine EKG at their primary care doctor's office, or it can be picked up, just by luck sometimes because you show up for another problem. If patients have symptoms, meaning shortness of breath, chest pain, racing palpitations, often it's a on and off phenomenon. So they go into their doctor, they can have an EKG, and it may make the diagnosis. Other times, if it's in one of those off phases, it's not there and you need a longer term monitor. So you may wear a monitor at home for up to 24 hours or even a few days to see if AFib or any arrhythmia is something that's contributing to these symptoms. Right, so the most important thing with AFib is that it can be caused by things that are not, due to the heart necessarily. Infections or like a pneumonia or even a urinary tract infection or other stresses on the body, even pain or electrolyte shifts can cause AFib. The important thing once it's been diagnosed is to decide where it's coming from. And once, if it's coming from the heart, then you need to determine is it coming from structural problem of the heart, meaning not enough blood flow through the coronary. Is there coronary blockage? Or is there valvular disease, either a leaky valve or a valve that's too tight? Those are all things that would need to be managed, and in which case AFib is more of a symptom of a greater problem to be taken care of. If AFib is a standalone issue, often the first-line therapy is medication, and there are antiarrhythmic medications that are given often by the cardiologists and can handle the problem. With atrial fibrillation, you also need to be on blood thinners, anticoagulation, to prevent those blood clots from forming. Depending on the type of atrial fibrillation, whether it's been very short-lived or it's been going on for years, will depend, and if it's managed by medications in and of itself, will determine if you need to do a more invasive approach. So cardiologists, first-line invasive approach is usually with a catheter. They'll take a catheter up through the groin, snake it up to the heart, and they can make burn marks on the inside of the heart to basically try to ablate these areas of the heart where this abnormal rhythm starts. Patients that have an enlarged heart or have had AFib for a much longer time have a much higher failure rate with catheter ablations. So then that moves to the next step, which is surgical ablation. Surgical ablation, which is relatively new from a minimally invasive standpoint, involves also making burn lesions on the outside of the heart and also getting rid of that left atrial appendage, which is a little portion of the heart where the clot forms that then often can fire off to the body. Historically, surgical ablation involved open chest, open sternotomy, cardiopulmonary bypass, big operation. These days we can do it with just a few little small port sites, about a centimeter, 3 on each side, and patient is still under general anesthesia, but patient has significantly less pain, recovers very quickly afterwards, and it has a higher success rate than the catheter ablations for AFib. We usually refer to it as a maze procedure because you're drawing lines that look like a maze on the outside of the heart to keep those electrical rhythms from propagating in the wrong direction. So this is based on the early surgical results, and then we have used, with new technology and new devices, we can deliver energy to, instead of having to cut and sew on the heart, we can burn these lines on the heart with equal effect. So we really try to have a collaborative approach between the cardiologists and the surgeons for patients that present with atrial fibrillation. We really want to give them the best chance up front of a long-term cure for the problem, get them off the antiarrhythmic medicines and the anticoagulation. In working together, often surgical approach can supplement catheter approach and vice versa, and we will plan to either do them at the same time or one after the other to give the patient the best approach. In terms of the surgical approach, there are very few surgeons that are fully trained at minimally invasive, totally endoscopic approach to AFib ablation. So we have that technology here at El Camino, and I think it's something that, as patients start to realize there's another option that they didn't have down the line, and the old way of just committing someone to long-term anticoagulation and life with atrial fibrillation is not necessarily what has to happen now.